Good morning, everyone. Today, we're going to challenge some common perceptions about hernias. For many, a hernia immediately means pain and surgery. However, the reality of diagnosis and management is far more complex and nuanced. We'll explore what a hernia truly is, the complexities of its diagnosis, the body's surprising healing capacities, the role of external support, and critically, the evolving discussion around surgical intervention versus watchful waiting, including some surprising systemic factors that can contribute to abdominal wall weakness. Let's start by clarifying what a hernia truly is. At its essence, a hernia is defined by a defect, or an abnormal opening, a hole, in the muscle or facial wall of the body. Through this hole, an organ or tissue, most commonly a piece of intestine or fat, protrudes. The visible or palpable bulge that many associate with a hernia is merely a symptom or a physical sign. While most hernias do present with a bulge, it's crucial to understand that not every bulge is a hernia. Other conditions like fatty tumors, swollen lymph nodes, or even muscle strains can cause bulges. The key diagnostic differentiator for a true hernia lies in the presence of that fundamental hole and the protrusion of contents through it. Traditionally, hernia diagnosis heavily relies on a thorough physical examination. Clinicians will palpate the area, often asking the patient to stand or cough, which increases intra-abdominal pressure. If a true defect exists, contents are forced through it, creating a distinct impulse or push that the clinician can feel at the site of the opening, a hallmark sign distinguishing a hernia from other bulges. They also assess reducibility, whether the bulge can be pushed back inside. However, a physical exam alone cannot directly visualize the hole or assess the precise integrity of the fascia. This is where imaging modalities like ultrasound, CT, or MRI become invaluable. These technologies can provide real-time visual confirmation of the defect and the protruding contents, especially in challenging cases due to obesity, very small, occult hernias, or atypical symptoms. A significant point of discussion is the difference between generalized weakness in the fascia and a full-blown defect, and how this impacts natural healing. Fascia, our tough connective tissue, can become thinned or stretched at a microscopic level, leading to general laxity or a subtle bulge without a clear, defined hole. In these scenarios, where there's facial weakness but no definitive hole, addressing the underlying causes can absolutely lead to the bulge resolving or healing. This can happen by strengthening surrounding muscles, adopting lifestyle modifications to reduce strain, and critically, by addressing systemic factors like electrolyte imbalances. Patients on chronic diuretics, for example, often have low potassium, magnesium, and calcium, which impair muscle function and tissue integrity. Correcting these imbalances can improve abdominal wall strength, potentially resolving the bulge and avoiding surgery. However, when this facial weakness progresses to a discernible hole where tissue consistently protrudes, the medical definition of a true hernia, the body's repair response kicks in. Fibroblasts will lay down new collagen fibers, forming scar tissue around the edges of this structural injury. This scar tissue attempts to stabilize the area, but it typically does not regenerate the organized, elastic fascia required to bridge and close the hole on its own, especially under constant internal pressure. Therefore, for adult hernias with a confirmed defect, spontaneous healing is generally not expected. Unlike umbilical hernias in infants, where developmental closure can occur, adult facial defects tend to persist and often enlarge over time. Now, let's discuss the hernia truss. This is a supportive garment designed to apply external pressure to keep a reducible hernia or bulge contained. While traditionally seen as a temporary measure before surgery, it plays a more active therapeutic role in non-surgical management. In cases of abdominal wall laxity due to systemic electrolyte imbalances, muscle weakness, or early-stage facial thinning without a true defect, a truss provides essential mechanical support, reducing strain and alleviating pain. It also prevents the progression to a true defect by continuously supporting the area and reducing mechanical strain. Crucially, it allows time for the fascia and musculature to stabilize or improve, especially when coupled with efforts to correct electrolyte imbalances and improve core strength. While not curative for a confirmed hole, a well-fitted truss can be a valuable part of a holistic healing strategy. However, it does not close an existing hole, and precautions like ensuring full reduction before use and monitoring for discomfort are vital. The decision between surgery and watchful waiting is complex and involves a nuanced risk-benefit analysis, especially given the risks associated with surgery, including chronic pain. Surgeons weigh several factors. Firstly, symptomatology. If the hernia causes pain or limits daily activities, surgery is often recommended. Secondly, hernia characteristics like size and defect width play a role. Thirdly, the unpredictable but potentially life-threatening risk of incarceration, hernia contents getting stuck, and strangulation, blood supply cut off, is a major concern. Elective surgery in a controlled setting carries significantly lower risks than emergency surgery for these acute complications. Fourthly, patient factors and systemic contributors to weakness are critical. This includes lifestyle and occupation, overall health, and crucially, electrolyte imbalances. Patients on chronic diuretics, for example, are susceptible to imbalances that weaken the abdominal wall. In early-stage cases, addressing these imbalances might stabilize the condition without surgery. Lastly, patient preference and risk tolerance are central to this shared decision-making process. Watchful waiting is a recognized strategy for carefully selected, asymptomatic, easily reducible hernias. From a patient's perspective, understanding the numbers is vital. Patients often encounter varying statistics regarding surgical complications, particularly chronic pain. While some research indicates chronic pain rates of 10 to 15%, encompassing any degree of persistent discomfort, experienced surgeons often report much lower rates, sometimes as low as 1%. This discrepancy often stems from differences in the definition of chronic pain, variations in surgical techniques, and the surgeon's personal expertise. Similarly, the annual risk of a hernia causing a serious complication like strangulation is often cited as low, for example, 0.2% per year for certain hernia types, but it's important to remember that the cumulative lifetime risk is higher. These figures underscore the importance of a transparent discussion with your surgeon, clarifying their specific outcomes, the lifetime risk of your particular hernia, and how your individual health profile and lifestyle influence the overall risk-benefit analysis. In conclusion, the journey from a bulge to a hernia diagnosis involves careful clinical assessment, often augmented by imaging. While the presence of a hole defines a true hernia, the decision to operate is a complex, individualized judgment call. It balances the potential, though often low, risks of elective surgery against the unpredictable, but potentially severe, risks of leaving a hernia untreated. Understanding these nuances, recognizing potential underlying systemic factors like electrolyte imbalances that can weaken the abdominal wall, and engaging in thorough shared decision-making with your healthcare provider are paramount to making the best decision for your health.